fortunate today to interview my close friend Mark Constantian, who was a classmate of mine, or with me, at the University of Virginia in the 70s, and also the author of the quintessential two-volume text on rhinoplastic surgery, and probably one of the greatest, or the greatest rhinoplastic surgeon in the United States today. Mark, pleasure to see you again.
For that introduction. I couldn't
What
have
can
written
you
it better
say?
myself.
So the interview starts out pretty simply. Please state your full name and date of birth.
Mark Barber Constantian. My birth date was December 19th, 1946.
And could you tell me what your parents' names were?
My father's name was Harold Constantian. My mother's Anne Constantian.
Was there any medical attachment with them, or what were their?
My father was a urologist. My great-grandfather was a physician first in Palestine, and then because there weren't enough Armenians there, he moved his family to Turkey. So one of the photographs I've sent you was a photograph of he had to get recertified as a physician when he moved to Turkey. So I have that in my office, all the documents. He had to pass the examinations again. Right. It happened to be signed by Abdul Hamid II, the man who started all the pogroms against the Armenians. In 1909, 1908 is the date of this. And then also I have a photograph of him at this Scottish missionary hospital in Palestine where he worked.
Wow.
So that's kind of nice. I've got that hanging in my office. There are stories about him being taken up into the hills by the bandits to take care of their sick, and then they, fill up his arms with lots of stolen loot. They had to pay him off for what he'd done to take care of the hoodlums in the foothills, and wow. He'd go back to town, give this stuff away.
That would have been a great oral history.
Yeah.
Yes. So you were born then in the United States. Where were you born here?
Born in Worcester, Mass. My parents were born here too.
Okay, okay. And how many children you have? Grandchildren?
My wife and I is a second marriage for each of us, so together we have 4 boys, and we have 7 grandchildren. There's another link too I should mention, and that is my maternal grandfather. This is my great-grandfather was the physician. My maternal grandfather came over here as a refugee to the Worcester, Massachusetts area and lived at a farm owned by the Tomajan family, which took care of these immigrant Armenian boys when they were working at the wire mill in Worcester, and he was Kazanjan's roommate.
Huh.
So they knew each other from the time they were teenagers on.
Wow.
And maintained a friendship. I wrote to Constantian when I was actually at UVA to see, but he was elderly then. I don't think his daughter wrote me a nice note back, but I don't think he made the connection anymore at that time. I never met him. My mother says that when she had met him, he claimed my grandfather, he said, was always smarter than I was because he learned English better. Constantian's English was never that good. Yeah.
Okay, so would you tell us where you met your wife, Charlotte?
We both lived in the same small town. Our kids knew each other, and I'd see her occasionally at church, but the kids were in school together. They played basketball together. They were in scouts together, and I needed someone at the time to work part-time in my office because I had developed some computer software, like a flight simulator, so that people could do rhinoplasty. This was 1987. Between 84 and 87. I had put together 3,000 images on a computer with a medical illustrator. Somebody wrote the software. I worked out the pathways because it took 8 megabytes, a huge amount of memory for a personal computer in those days. And you could go down each of these pathways if you didn't like, and look at the nose from the surface, look at the skeleton, and as you did each surgical step, reduce the dorsum, do the tip cartilages, osteotomies, shorten the nose, spreader grafts, radix grafts, tip grafts, all the different things, the maneuvers. Then, if you didn't like what you saw, you could back up and try a different pathway, or get a hint, or get a complete teaching explanation. And at the end, the computer would reconstruct what the nose would look like after it had healed, after soft tissue contraction had occurred. So I had all this stuff, and I needed someone to test out, make sure all the pictures were in the right places and all the text was in the right places. So I hired her to do this as part-time work. And then she got more and more indispensable around the office, and pretty soon became the office manager, and 7 or 8 years later we got married.
And I know she's been an integral part of your practice because I've known her for years. It just is
What a partner.
She's a partner with you.
Absolutely.
And
Everything important I've done in the last 30 years has been with her.
well, I think somebody once said, behind every great man is a woman.
Yeah,
And
I
I know how much work she's done in addition to the societies that, you know, she organizes the trips and everything.
Oh,
So
yeah.
you've got a great partner.
Thank you. I know that.
And what inspired you to go into plastic surgery?
I actually, when I was at UVA, I liked the thoracic cardiovascular service the best. It was just the most fun, the residents, and we were just, you know, at that time we were all doing the valve replacements for all the people that had rheumatic fever and needed aortic, and Harry Muller was there, the first aortic valve pioneer, and he was the chief, and I loved the physiology of that. So cardiovascular surgery was what I thought I was going to do. And then, as we both know, Milton Edgerton came to UVA the same year I got there, because I had transferred after finishing at Dartmouth Medical School. So in 1970, I got there for my last 2 years, and he got there. And I remember standing, I knew nothing about plastic surgery. It had never really interested me. I thought, it's nose jobs, ironically. It's nose jobs. And then life plays jokes on you all the way through, if you noticed. And so I remember looking in the window while he was doing a case. There was this big mystique, you know, the great Dr. Edgerton has come from Hopkins, and there was a certain amount of jealousy. I thought he was wonderful. And he must have been doing a cruisons, because he had these guide wires, and he was just at the critical point of pulling the midface forward. And I was blown away. I mean, I could see there were a couple of people there with him. Must have been Jack Fisher,
Right.
and whoever the intern on the service was at the time. And I thought, this is unbelievable.
Ehrlich was probably there.
Yeah, could be. Edlich, Dick Edlich, yeah.
Sorry.
And that's what made me start thinking of plastic surgery. And then Jack Fisher and I had become friends, because he was Edgerton's first resident there, and then I went up to Boston University and ended up doing the same immunology lab that he had been in. So we kept contact through that whole time, and I began to get more and more interested in it. And that's when I decided, probably 3-4 years into general surgery, that I was going to go on to plastic surgery afterward. And I did.
Well, in deference to Dr. Edgerton, in our class of, what, 84, it wasn't a large class, never is. And I was the only one that wanted to be a plastic surgeon. You weren't there when in '68. I guess it was '68 when I started. And everybody said, "Why would you want to do plastic surgery?" And ultimately, 4 members of our class, me, you, and Wally Redinger and Gerard Grau, became plastic surgeons. So I guess it wasn't too bad an idea, but of course Edgerton was the stimulus for that.
Definitely.
Other mentors, because I want you to talk about other mentors in plastic
Well, my
surgery.
big other mentor was Jack Sheen. He probably influenced me more than anybody, not in just partly in rhinoplasty, but it was also the way he looked at plastic surgery and the way he looked at what he did. I finished my training in '78 and I had several academic offers, because I'd done 5 years of immunology research, and I'd done a lot of writing, and I'd been very prolific in that area. And but I really wanted to go someplace that was unserved, and southern New Hampshire, except for the 3 guys at Dartmouth, there were no other plastic surgeons in the state. And Peter Passig was in Manchester, but had a very sort of specialized practice. And basically, there was nobody else in the whole state. And so I went to southern New Hampshire, and I thought I had 2 months between finishing my plastic surgery in Virginia and then moving up to New Hampshire. And I thought, well, I'm studying for my written boards, I might as well go watch this guy Sheen operate, because his video was the only one that had made sense to me. I never understood rhinoplasty from the textbooks. And so I went out to watch him, and it was a huge experience. It was like Eric Clapton hearing Robert Johnson. It's like, whoa, he was so technically good, and he was so iconoclastic. He said, my great advantage is I didn't know the literature when I started. Now, I mean, that's sort of, he's being facetious, but what he meant was he didn't pay attention to the literature. Just because it said supertip deformity was because of under-resection, and he thought it was over-resection. It didn't stop him from trying different things, because he just thought the results that were coming out and were not as good as they could be. Function was bad, and all these patients that had rhinoplasties and had bad results couldn't be helped, because when we were residents there was no such thing as secondary rhinoplasty. And so the way he looked at it, the amount of excitement he had, I watched him periodically all the way through till he retired, and even the last year he was working, it was still, did you see that? Look at this. It was always this kind of intense
Intellectual
fascination with it, and constant elaboration of his ideas, and constantly working out what wasn't right. I really admired that.
Well, I remember, of course, his book on
Yeah.
rhinoplasty is an iconic text,
Yeah.
like yours.
Yeah, well, thank you.
Except yours is 2 volumes.
Yeah, well, his second one was 2 volumes. I saw his first one before it was ever published, because when I was visiting him in '78, it was in a mimeographed form, and it was at the publisher. It hadn't come out yet, and he was very nervous about whether these ideas would be even accepted by anybody. I said, this is wonderful. I get it. I read through the whole thing. It's 200 pages of mimeograph paper and photocopies, and I said, this is going to be great. This is going to be great. He was still skeptical, but it was. I mean, he became like a rock star.
Well, first of all, to me, he defined the aesthetics of the nose, which nobody really had before.
Yeah.
Second thing was, I'll never forget a meeting, I'll let you, I thought this was great, I'll never forget it. He's up there and everybody, he's the rock star.
Yeah.
And he says, well, I'll see a nose and I'll tell them that I can't, there'll be secondary, tertiary, quaternary rhinoplasty. Well, you know, this problem was, if somebody did a secondary, they just made it worse.
Yeah.
And he'd take on these horrible, terrible results. And he'd say, and I'd tell them that I can't do a miracle, and I'd remind them again I can't do a miracle, and I would tell them again. He said, then I'd do a miracle. And only Jack Cheek, because then he'd show the results, and everybody's like, seriously. It's like, wow. So, anyway, that's...
and he was constantly pushed to elaborate things, because as people, he wrote about putting septal cartilage in. Then after a while, all the patients he saw had already had septoplasties.
Yes.
So he said, I have to stay one donor site ahead of the other surgeons. So ear cartilage came along, then cranial bone, and so on.
Yes, yes. So you see momentous shifts in plastic surgery during your career. Just tell us a little bit about them.
I think one of them has been managed care coming in, and the commoditization of plastic surgery, medicine really, where every doctor's interchangeable. That's not good. The effect of the internet certainly has made a huge difference, where surgeons can make themselves out to be anything they want. Patients can go on, the unhappy patients can go on and really hurt a surgeon's career. They can exchange information that may be completely bad, and it all gets propagated around. The other part of managed care is that with better anesthesia, patients stay in the hospital less and less. You know, when I was an intern like you were, patient would be in 10 days after herniorrhaphy and 2 weeks after an open gallbladder, and if they came in and they had a little spike in fever, or the white count went up a little bit, and you'd actually watch them have a pulmonary embolus and then watch them get better. So you got a sense of the whole natural history of disease, because patients were in so much time.
Right.
Now, everybody's done as an outpatient. All the catastrophes happen at home. And then, of course, the other big change has been the resurgence of open rhinoplasty since the mid-'80s, which has changed that operation completely.
Yes.
Made really rhinoplasty two kind of incompatible languages now between open and closed.
Yes. All right. So what do you feel has been the most important innovation in our specialty?
Probably advances in transplantation, but that's only like the tip of the spear, because when my great-grandfather started practicing medicine, it was Osler's time. You know, they could diagnose, but there was nothing they could do about it. They had digitalis, and they had morphine, and they had thyroid extract, and that was about it. Then my father's generation came along, and they had antibiotics, and vitamin B12 for pernicious anemia, and so on. So all of a sudden, a lot of infectious diseases became curable. so that by our generation, we expect to be able to do everything. We don't expect to be confounded. You know, and I have a couple of friends now who are very sick, and it drives me crazy that there isn't a solution. There has to, we can do everything. How come we can't do this? And so I think it's been a mental change in our generation too, of expecting everything to have a solution. That's good because it keeps pushing people, but it's frustrating because we're never going to get it all.
Well, I think I know the answer to this one, but what do you feel has been your greatest professional accomplishment?
I think, I don't consider myself a technical innovator, but a lot of what Sheen did, he did instinctively. And even I had trouble learning from him. I think he's not telling me everything. And it wasn't because he was trying to leave it out. It was because he did things unconsciously. He'd make a correction, and then I'd say, "Why did you do that?" "Well, I don't just seem like the right thing to do." So I tried to interpret what he was doing so I could explain it to other people. And that's been really gratifying to me because I tried to model my textbook on his second edition, which has thousands of photographs and hundreds of case examples. So surgeons could go through and look, I've got a case like that tomorrow, with diagrams and lots of intraoperative photographs. And when surgeons write me and they say, "I read the book and I've been in practice 3 years and these are some of my cases," and they're way better than anything I could have done 3 years into practice, I think that's fantastic. So that's one thing, I think, kind of translating Sheen's ideas. Second, I measured some of the things he did. You know, I did this 600 patient airway study over 17 years, an outcome study before, a level 2 outcome study before there was anything by that name. So I know exactly how much spreader grafts do, I know exactly how much dorsal grafts do, exactly how much fixing the external valve does. And I've been able to quantify that so people have got real measurements to, and I think anything that impacts the airway has to be measured. You can't just come up with an idea and say, "This is a great way of fixing whatever," and not prove that it does, without proving that it works. And if it works better than what I'm doing, I will switch. So those two things. And the final thing is, I think I believe I have made a strong connection between childhood abuse or neglect and body shame and body dysmorphic disorder or immature behavior of patients, that explains why a very good result can upset a patient, why they get so irrational you can't reason with them, why they'll get on the internet and try to destroy the doctor, why people become obsessed or addicted to plastic surgery, that's what I'm working around now. But I just presented with a couple of the residents from the University of Wisconsin data on 100 consecutive postoperative patients of mine, and you know, at this point my practice is mostly secondary rhinoplasty. These are mostly people with disposable income. It's not a disadvantaged group, and giving them a 10-question screen of 10 different kinds of childhood abuse or neglect, 80% have at least one positive answer. I mean, I think that's stunning, because we think of our patients, they come in, they're successful, they're working, they've got good incomes, they've got disposable income, they come in all nice and adapted and asking for a very reasonable thing. You'd think their lives can't have been that bad. But the other aspect of it is what I call resilience. The reason I only tested postoperative patients was that I wanted to be able to put these people in context. I wanted to know how they had behaved going through their operation and how they managed emotionally handled everything, how difficult were they to put up with, and so on. And there's no connection between the amount of childhood abuse and neglect and how well these patients were running their lives. So the most successful, most happy, most easy patients didn't necessarily have the easiest childhoods. There's that extra human factor of being able to make it despite everything, which I think is really the best part of the story.
Well, I appreciate that, and I agree with you, and I have to say that part of the reason of this interview is we're making an assumption that really a lot of people ultimately discover in plastic surgery the rhinoplasty is extremely difficult, procedure to get consistent results. And I've heard it more than once. You really don't know what you're doing until you've done 500. The problem is today, some young people won't do rhinoplasties.
Right.
I'll say, I can't do, I don't want to do that. And they train at good programs. I see people from Southwestern, Jack Gunner's there and his group, he doesn't practice anymore, but is it, how could you say I don't want to do rhinoplasty? That is such a great challenge to write a premier text that is beautiful. I mean, when I wasn't just giving you my opinion because you're my friend, but your results, your photographs were so unbelievably consistent. You know, it's because there's articles about consistent photography. You can make somebody look like they had a facelift or 5 years younger, depending on the lighting. Everything you did was honest and consistent, and is reproducible.
Well, thank you. I mean, when people can carry out my ideas, that's good. The photographs came about in self-defense in a way, because when I started, I did the first 2 or 3 cases, and I had no idea what I was doing. I couldn't identify the anatomy. I thought, this is dumb. This is 4 cartilages and 2 bones. How can I look in there and not even know what I'm looking at? And the changes were not ones that were described in the books. You know, you reduce the dorsum, and only one thing is supposed to change, and all of a sudden there's all these other things. So I started taking sequential pictures, because I thought there's got to be a code here. I've got to figure it out. I never had an ambition to be an expert in anything. I just wanted to do competent surgery, and I figured this is why I went out to see Sheen. I wasn't looking to be a rhinoplasty guru. I just thought, I'm going into private practice, there's nobody around, it's like bread and butter surgery, I've got to be able to do a competent operation, or I've got to not do it. So it was only because I wanted to do a serviceable job for my community that I started trying to crack the code, and then I got interested, and then I started writing papers, and went from there.
Well, you did a great job, and still are.
Well, thank you.
Okay, as a specialty, what do you think our greatest mistake has been?
Well, you have to take this from whence it comes, since I don't train, I'm not a training program director, and I've trained some residents as they come to visit, but never through. I think the integrate program has been a mistake. I think that the medical student coming out, deciding he wants to be a plastic surgeon, and then getting whatever he gets from general surgery, at the end of that time, a lot of them are taking fellowships. I think a lot of them are taking fellowships, they tell me, because they don't feel ready to go into practice. The kind of training you get in general surgery with these really sick patients, and of course we got a lot of operative experience that you don't necessarily get in general surgery training. I think it just equips people differently. I never felt worried about going down to see a multiple trauma patient. The orthopedic guys would get there and say, I'm not touching the patient till the general surgery has cleared them. And I always thought that was kind of funny, and I was glad of all the years I had spent. But I'm concerned. I mean, people are now taking extra years on top, and I think that makes up the difference. But the really complicated head and neck cancer reconstructions, the really intricate things that plastic surgery became so known for, I hope we're training enough people that will continue to do all that and not give up the hard stuff. So I think that's what made us.
I agree.
The stuff nobody else could do.
What has been your greatest professional disappointment?
I think not being able to feel after more than 30 years of teaching rhinoplasty that most people get it. Rhinoplasty, we talked about this last night, what a MacGuffin is. A MacGuffin is a device Hitchcock talked about, which is the goal of the hero in a movie. So the MacGuffin in The Maltese Falcon was the statue. The MacGuffin in rhinoplasty teaching ought to be having the whole audience get everything by the time at the end of the symposium. And I don't think it is. I think the MacGuffin is competition, and my way is better than his way. So there's not, we're not all building on each other's work. The two open and closed rhinoplasty have gone in such different directions that people listening the basic stuff can't be agreed upon by the faculty. We don't have good outcome studies. We don't have enough reporting of complications. So surgeons listening, okay, this is what the guy with the biggest microphone says, I guess I better do that. And then they have all kinds of new complications, and they conclude, I'm too stupid to do this operation. and they stopped doing it, and I think that's a mistake. So I think rhinoplasty teaching has not made better surgeons. It's not made better outcomes. The results I'm seeing that need correction are worse than they ever have been, and I think that's where we've really lost something.
Do you think that per capita rhinoplasty has decreased, and that might be one of the reasons that we're so diluted now with other professions? Do you think just, and you do secondaries and tertiary, et cetera,
Yeah.
type rhinoplasty, do you think rhinoplasty is as popular in operations as it once was, or do you think we've moved, I won't say evolved, because we've moved to a different concept based on TV enhancement and whatever with regard to cosmetic surgery?
I think it is in numbers. If you look at the gross numbers of rhinoplasty
Yes.
that are being done, there are not a lot of them as many being done by plastic surgeons. And I think that's for a couple of reasons. I think a lot of surgeons are uncomfortable with it, and they say life is too short to put up with these patients and have an unhappy result. And I do just what I was taught, and it looks horrible, because the basic stuff has been completely forgotten. I was just at a meeting at the Aesthetic Society Symposium, and somebody presented a paper on what makes the upper lip longer. Now that should be general knowledge, but those kinds of basic phenomena have been lost over the last 25 years or 30 years because people don't see the nose from the outside anymore. They see all the micro stuff. So the basic, and what makes noses longer, what makes noses shorter, these phenomena you used to see when you did them closed because you were getting the macro appearance all the time. And managed care has made another difference. If you're a primary care doctor, you see somebody nose, goes to ENT. So I think that's possible to reverse that. I mean, I did in my city because I learned how to make excellent airways, and the patients were happy. And so they started coming to me. The doctors would refer them, the primary care doctors, because they knew they were getting a different product than just the deviated septum fixed. So I think it's possible to break out of that in your community if you put the effort into it. But if you don't have the founding to understand the phenomenology and don't understand the rhinoplasty as a whole, it doesn't matter because the results won't be good. That's the other danger of the internet, because people can portray themselves as having a skill they don't have yet.
Right. But what has been your greatest joy?
I think teaching the residents, I think, has been a lot of fun. Writing something that someone then can take and go to the operating room and do it and send me pictures, just having read my book and say, these are my results, and what you're doing, what you say works. That's been wonderful. Charlotte and I also founded an aesthetic lectureship at the University of Virginia. That every year, some other aesthetic surgeon will come down with me and spend a day with the residents. We have cadaver dissections. He will spend a day with the residents by himself, showing them the surgery, lecturing to the department. Then the next day I do the same thing.
What is the name of the lectureship? I forgot.
It's the Constantian Aesthetic Lectureship.
Okay.
They've got a craniofacial hand reconstructed, and this is the aesthetic one.
Okay.
So I did the first one, Glenn Jelks did one, Sherelle Aston did one, so we're rolling along. That's been good. And I've also got bequeathed some money in my will, unless I spend it all first, that will help the residents in the department get partly medical school scholarships and partly allowing plastic surgery residents to do overseas travel.
Whom do you admire most, either professionally or personally?
I had a teacher in the 7th grade that taught me to write, Mary Hawkyard. She was a huge influence on me. I had a bishop that was a friend of mine for many years, the retired bishop of Southwestern Virginia. He married Charlotte and me, but he was a role model for me. Certainly Jack Sheen was, and Bob Goldwyn, I would say. We were very good friends, and Bob came from Worcester also, like I did. His father was a psychiatrist and a contemporary of my father's, a little older. And I just thought Bob was a wonderful man with the right. He never lost the humanistic side of medicine, and I think that's why we all like reading his editorials and knowing him so well.
Yes. He was a great man, a great editor.
Yeah.
would you give us your words of wisdom for present and future plastic surgery residents?
I think if I were starting again, I would do just what I did. I would go someplace where I was needed, go to an underserved place. I think to me, it doesn't make sense to go to Beverly Hills and start trying to do cosmetic surgery. I mean, I would go somewhere where they really needed me. I don't think, if your interest is aesthetic surgery, I don't think you could be a good aesthetic surgeon without being an excellent reconstructive surgeon first. All those years of reconstructive surgery taught me to manage complications, understand patients, get technically better. I think trying to jump into aesthetic surgery right away, even if that's your goal, is a mistake. I think surgeons have to make things make sense to them. Medicine is very logical. It's got, surgery's got rules, biology's got rules, and some of the things I hear now, particularly in rhinoplasty teaching, are just wrong, and in the sense of what we all know. You can't hold things open with sutures under tension forever. Eventually they break through.
Right.
You can't reconstruct noses infected with implants immediately by putting a rib graft in. You can't widely dissect a very scarred nose and then close it under tension. You're going to lose tissue. And these things all happen, but they're still being taught like they're great ideas. And the surgeons have got to say, wait a minute, this doesn't make sense. So I think people should listen to me with skepticism. I think they should listen to everybody. Make sure that what you hear is tested, and you've got outcome studies, you know what the complications are of a technique, that you get the whole picture from the surgeon, not just, this is my great idea and here's a case where it went beautifully. That's not enough information, so be cautious.
When I was a resident, I have to say I'm so glad in Akron we were required to read Peacock's book.
Yeah,
On
yeah,
wound healing.
yeah.
And the principles of plastic surgery, what you say, if you think you're going to close something with 3/0 rope,
Yeah.
it's going to open up.
Yeah.
It's just, it's enough. And
Yeah.
I think that goes forward to rhinoplasty, is the principles of airway. It's like the butterfly can
Yeah.
change the course of history. Changing one thing in the nose is a
Yeah.
domino effect and
Yeah.
changes everything
Yeah.
else.
I remember being given the Weeks and Ray book on hand surgery, and I didn't like it because it made me think of biology too much. I wanted a nice simple atlas that was going to teach. It was exactly what you said, but that was where the real book was. The other thing is that I want surgeons not to forget their physicians. Don't become the technician. Don't look at too narrow an area. I often see patients, now that I'm doing all this trauma work and I'm talking to people more about their childhoods, people come in who've had, they've been morbidly obese, they've had bariatric surgery, they've had all kinds of body contour surgery, and in talking to them, they'll tell me about all kinds of abuse that they've had, which is very, very common. It's the majority of people who've been morbidly obese. And they'll say, you're the first person that's ever asked me about this. That's not right. They've gone through a lot of doctors who did, all the people that did their bariatric surgery, that counseled them, that then did the body contour surgery. There's a lot of opportunities here for someone to know more about this patient. And then the occasional patient that goes off the rails because their motivation isn't dissatisfaction, it's shame produced by trauma. The surgeon's completely clueless because he or she has no idea where this came from. So I think that we have to think always the bigger picture.
Well, I have to congratulate you. And when I was with Edgen, I wrote a paper once on the psychodynamics of rhinoplasty. Very few, and it's a hard area to transgress when you really want to get into the lives of somebody, because you enter something different. They appreciate that. It gives you an understanding, but it's a difficult step for people to make, and it's not taught. We take psychiatry for 1 month. That's it.
Right.
We move on to the next subject. So I think the way you look at it is a paradigm shift of what's been going on the last 10 or 20 years.
Well, and for me, as I've thought about it, it's kind of closing the loop too, because I started with Edgerton, and now I'm getting back to talking. I go back to the 50s and 60s. He was writing about the patient with the minimal deformity and the insatiable cosmetic surgery patient. Yeah, and I've talked to Dr. Edgerton about this, and he gave me, I have read through this 4 big loose leaf notebooks of a book he was never able to get published, 100 of his most difficult patients. And he's got very detailed histories, and a lot of them had childhood abuse. And I talked to him about this, and he said, you're right, I never noticed that. And it's a very consistent picture. And so I'm glad I've been able to add that piece to something that he was way ahead of his time
Yes,
to recognize.
I agree. So I know you're not retired, but I'd like some words of wisdom, what you plan to do, and you can mention your guitar.
Well,
passion.
my wife keeps laughing because she says Mark's been saying he's going to retire in a few years for 5 or 6 years now, and it'll still be a few years. I think the important thing is to stay creative. I do love playing guitar. I like to sing. I like to go to the gun range and get better as a marksman and do competitive stuff. So doing something where you're using your imagination and you're creating something. Sheen became a wonderful sculptor. She sent you a picture of a sculpture he did of me as a favor. But he could do fantastic portraits. But I mean, we know so much anatomy, and putting his hands in and being able to create it, that's wonderful. And I think, surgeons learn for a long time. I know I can do stuff now I couldn't do even a couple of years ago better, and I've got it more figured out. So even when I stop operating, I think as long as we're able to make contributions in some ways to young surgeons, we should.
Okay, the final question is, what do you see for plastic surgery in the next quarter century? Prediction.
I think it depends a lot on the economy. If it becomes impossible to make a living doing reconstructive surgery, that's all going to end up mostly at the medical centers, where the hospitals can reimburse the surgeons more than they're actually bringing in, and that would be a crime, because that's so much of what we need to do. So I think some of it's that. I think there'll be, I hope, a modulation of what we know about rhinoplasty teaching, so that it gets better, and the current confusion of surgeons saying, I'm scared of this, I'm not going to do it, I'm going to give it up, the faculty will be able to come to a better consensus and be able to teach it in a more unified way. The other thing is, I think what we're just talking about is that there's so much beyond the surgical problem that we have to know about patients to understand how to treat them. Plastic surgeons can make a unique contribution to the body image literature, the body dysmorphic literature, because all those mental health specialists and body image psychologists see the patients through surveys, or they see them little tiny snapshots. We see them in context, coming in, going through an operation, having a complication, coming in with an illness, a burn, or whatever it is, and we can put a whole background together that is impossible for the other specialties to do. And we see functioning people who are looking for surgery. They see patients who are going for psychotherapy for body dysmorphic disorder. They're the delusional housebound patients. They're not the ones that come into our offices. Right. And this is where plastic surgery has been kind of missing in action. And we need to get much more involved in broadening the picture. I think shame-motivated surgery is probably even more important, or maybe a better name for it, than body dysmorphic disorder, because a lot of the patients that come in to see me don't have imaginary problems. They're totally real, but the patient's motivation is not correct, and their ability to handle the issues and their ability to act like functional adults is not correct. And the other side of that, too, is that all we surgeons have our backgrounds. You and I grew up differently. We all have different stimuli. We can tolerate different kinds of patients. We select different kinds of operations. We function better in certain circumstances. And I think as surgeons learn more about themselves and recognize that we all have our own histories, we'll do better taking care of patients.
No, I agree. I think that aesthetic surgery, the definition is surgery performed to make a person feel better about themselves.
Right.
But there's a whole spectrum about feeling better about yourself, because
right.
you may do the most perfect surgery in the world. That doesn't change their self-assessment or opinion one iota.
Right. If the patient's got dissatisfaction, they're the perfect plastic surgery patient. They come in with a discrete problem, you fix it, they go away happy, they go through it easily. The patient who comes in who's motivated by shame, body shame, which is the commonest kind of shame to come out of childhood abuse or neglect, is looking to feel like they're worth something
Right.
because of the surgery, and that's hopeless.
Well, I appreciate that contribution you're making, because that's out of the box thinking right now.
Yeah, those people need trauma work.
Yeah.
That's my next step, is to figure out how to get what the right kind of community-based treatment would be for these people, because there's a lot of them.
So I guess you won't be working on cold vision anytime soon.
No.
We-
Nor retiring, probably.
Okay. Now, I want you brought this
Oh, yes.
gift that Dr. Sheen gave you. 'Cause we
Yeah,
asked you to
it's,
bring
you said
something.
bring an artifact, and this is the nicest one that I had. I thought, this is a prototype of the cartilage crusher that he created to crush rib cartilage. You can buy the current version now. It's not quite like this, similar, but this was his prototype, and he's inscribed on it, "Passing the baton to Mark Constantian and Jack Sheen, October of 2000." So this sits on my shelf, and this is I'm trying to carry out what he started and pass it on to the next group of surgeons who will pick it up from me.
Well, I know he would appreciate that. I thank you so much for coming
My
in
pleasure,
today,
David.
my good friend.
Always good to see you.